Hi, I'm Myles Sheehan. I'm the director of the Pellegrino Center for Clinical Ethics here at Georgetown University, and I'm happy to be part of this KIE symposium. My presentation today is on a topic, professionalism, and I call it Revisiting Professionalism. But first, let's think about the meanings of that word. And frankly, it's something of a catch-all term. For those of us who are in the healthcare profession, sometimes it can mean how you dress or behave or interact with other healthcare workers. It can mean your focus and care for a patient. But professionalism can also be an ambivalent term in that it might hide the maintenance of a status quo of prestige and self-interest. And at a time, particularly over the past year, when serious disparities have been exposed in healthcare outcomes among Black, Indigenous people of color, one can wonder if professionalism can also be supporting structures of racism and injustice. William Butler Yeats has a poem called The Second Coming, and I think it fits well for our time. Turning and turning in the widening gyre, the falcon cannot hear the falconer. Things fall apart, the center cannot hold. Mere anarchy is loosed upon the world, the blood-dimmed tide is loosed, and everywhere the ceremony of innocence is drowned. The best lack all conviction, while the worst are full of passionate intensity. Well, what are the things that might point to problems with holding the center? As you know, there's a lot of activity in terms of hospital mergers. There are a variety of changes in insurance structures that have gone on over the last 2 decades. Individual practices have been bought out, and there's been the formation of PPOs as well as other health provider groups. There is an incredible amount of regulation and institutional scrutiny. We've had the diagnosis-related groups for quite a while, but they still provide, in some ways, a challenge as to how we code, how we bill. Increasingly, physicians can be forced to be extremely productive in ways that may make individual physicians feel that he is not giving the best care possible. There are limits in hospital stays with pressures to discharge people far faster than we did in the past. There remain the threats of malpractice suits with high insurance premiums. And so among many of our colleagues, we find exhaustion, burnout, lower salaries, harder work, less respect, more scrutiny, less opportunity to care, seeing more patients and limited time for those that perhaps need more time. Against this, we have what has been a chronic problem, but perhaps has been exposed in a dramatic way during the COVID pandemic with a lack of healthcare access, poor results, bad outcomes for minorities and the poor. Paradoxically, the healthcare professions have had some renewed respect because of the pandemic related to the heroic professional behavior of many healthcare practitioners. So what I'd like to do today is to discuss some different models of professionalism. I'm going to review this from the perspective of Dr. Pellegrino, who, as you know, is sometimes called the father of modern medical ethics, at least in the United States. Explore a little bit of what's called the dark side of professionalism, try to provide you with some information for you to consider what it means for you as a person to be a member of the medical profession. And I'd like to advance a progressive idea of the profession that recognizes faults and injustice and moves to correct. Now, a traditional model of a profession comes from a sociologist, a gentleman by the name of Friedson, who wrote a book in the late 60s called Sociology of Medicine. And he looked at 4 different components that he found in his analysis to be part of a profession. The first is extensive and arduous training, and we certainly go through that in medicine. That training gives us skills and knowledge which are of benefit to society in the ways in which we can provide relief for disease, prevention, caring, etc., for those who come to us. As a consequence of the skills and the benefits that are provided in professional practice, along with the somewhat arcane knowledge base that we have, considerable professional autonomy is given to the profession, But as part of that social contract, if you will, there are obligations to society as part of this grant of professional autonomy. Well, what are those obligations? Well, it's presumed we're going to act in the patient's best interests. We'll maintain confidentiality with some exceptions, for instance, public health measures or a patient who's suicidal or homicidal. We'll maintain technical competence and provide skilled service. There is, in some ways, an obligation of self-effacement. Responsibility to the patient comes before personal interests, and we've seen this with care in the pandemic, responding to calls to not abandon a patient for a variety of reasons, including financial. We're also expected to be financially honest and to do things like coding accurately, to bill appropriately. And then finally, the responsibility for professional self-regulation. The problems have been the increasing financial pressures and concerns that some may be putting money before patients. With managed care and all the variety of different plans that are out there, there are concerns that the patient's interests might be compromised in efforts to cut costs to secure a maximum reimbursement. There has been a perceived lack of self-regulation of impaired or abusive colleagues. Part of this involves poor behavior of some physicians towards colleagues, nurses, and students. And along with that, there is perhaps a concern of a general erosion of our moral compass. And in a separate trend, which isn't necessarily problematic, but it does change the way in which one looks at a physician, there have been the development of procedure-based subspecialists with very narrow focus and not an attention to the whole person. Now, Dr. Edmund Pellegrino viewed medicine as a distinct profession, and he said that the goal of the profession, as he would say using the Greek, the telos, the end for which we have, is to find the right healing action for the person before us based on a fourfold good. And those goods include the medical good, the patient's good, the human good for that patient, and the spiritual good for that patient. And he would rank these from lowest to highest, with the biomedical good being the lowest, but they interact and it's not easily separable. And the physician's active profession is to promise dedicated care and service to the person who is her or his patient. And this should come before anything else and is at the center of professionalism. Dr. Pellegrino wrote, "All healthcare professionals, especially physicians, must remind themselves of certain existential realities upon which the moral quality of personal relationships depends. Those we treat are patients, not consumers, clients, customers, insured lives, items on a balance sheet, or center of profit or loss. We are physicians, not providers, case managers, fund holders, contractors, or mere job holders. When one asks a patient, 'What can I do for you?' one promises to act for the good of the patient, not merely to avoid harm. Every day that we practice medicine, we make an act of profession, a public promise that says we demand more of ourselves as person than a mere occupation requires. Every day that we practice medicine, we recommit ourselves to help, to care, to ease suffering, and to cure whenever possible." Likewise, Pellegrino viewed physicians as constituting a moral community, as he said, a moral community with enormous moral power. We commit ourselves as a group. Every graduating medical class takes an oath at graduation where its members promise publicly to be competent and act in the interest of the sick. By this public promise, we become a moral community. Physicians cannot be indifferent to injustice, inequality, and suffering caused by our system of healthcare, by an institution's insurers, or by our own professional self-interest. We share a collective responsibility to be strong and clear resources for a just healthcare system, for the competence of our fellow physicians, for the rehabilitation or expulsion of those who violate the moral demands of what it means to be a physician. We must use our moral power wisely, well, and not in pursuit of the profession's interests. But is there a dark side to this? Well, it has been posited that there is. And over centuries, professionals have used claims about what is good, allegedly, to foster and protect themselves at the expense of patients and the public. Regarding the dark side, part of the power of labeling someone as unprofessional is to squelch individual differences in self-expression. For example, one black doctor told me that she was chastised as an unprofessional for wearing ethnic African clothing to the work. The same doctor was told that braiding the patient's hair on her own time was unprofessional. A different negative part is professionalism's power to injure its members. Its ethos can result in their self-neglect, burnout, or quasi-martyrdom. It can even lead one to abandon one's own family members and empty oneself of joie de vivre. This is the dark side of altruism as a virtue. Thus, a statement of professionalism's core might well be altruistic, but not too altruistic. In the late 1990s, Dr. Matthew Winia and colleagues wrote an article in the New England Journal about professionalism, and they acknowledged the dark side, that professionalism could be seen as a self-serving ideology that masks the reality of naked self-interest. And some of the concerns is that professionalism can be a way to maintain income and privileges, pretend that those who practice healthcare are more noble than other workers, and it act to undercut access to healthcare to promote power and prestige. Winia and his colleagues said medicine should be defined not by its distinctive characteristics, by its moral premises. And he said that professions protect not only vulnerable persons, but also vulnerable social values. When professionalism becomes unsteady, it marks the emergence of societal problems. In other words, institutions like a profession of medicine are part of the social framework, and that institution rests on moral premises. When our institutions become shaky, our whole society is becoming shaky. And so he had three elements to his model, and the first is devotion to medical service. That is, physicians must be devoted to the work of providing healthcare. His second element is that physicians and those in the profession need to be very clear, and that we need to have an explicit and professionally protected moral base so that they can be legitimate shared expectations. Through public profession of healthcare values, patients and the public hear about these values, as well as the standards that result from them. A public collective commitment to fulfill legitimate expectations implies an acceptance of accountability to one's professional actions, as well as an acceptance of the shared standards of the profession. So part of saying I am a member of the profession means to say, I will act in your best interest. I will put your interests ahead of mine. For us to say that is a way in which we reinforce that among the members of the profession and also in the public so that they know what they can expect. Dr. Winia and his colleagues also said that public professional values inevitably requires professionals to engage with the public in negotiating social priorities that balance medical values with other societal values. The challenge for physicians is to be accountable to the public and its changing values while protecting core healthcare values. And now I'd like to talk a little bit about some of the work done on the profession of medicine by Joseph Cardinal Bernardin. As you may recall, Cardinal Bernardin was the Cardinal Archbishop of Chicago, and he was diagnosed with pancreatic cancer in June of 1995. In his role as Archbishop, he also had oversight responsibility for a large number of Catholic healthcare facilities. Both his role as oversight in healthcare, along with his own personal experience, led him to reflect about medicine as a profession. And he wrote, "What do I mean when I speak of a moral crisis in medicine? I mean that more and more members of the community of medicine no longer agree on the universal moral principles of medicine or the appropriate means to realize these principles. Conscientious practitioners are often perplexed as to how they should act when they're caught up in a web of economics, politics, business practice, and social responsibility. The result is that the practice of medicine no longer has the surety of an accurate compass to guide it through these challenging and difficult times. In other words, medicine, along with other professions, including my own, is in need of a moral renewal." Bernardin's model had several parts to it. First, that medicine is a covenant between the patient and the physician, with the covenant grounded in moral obligations. It's based on fundamental human concepts of right and wrong. and the physician has responsibilities that come from this covenantal relationship. He said that your profession and mine have much in common, namely universal human need for healing and wholeness. So what special qualities do medicine and ministry share? First, we're both engaged in something more than a profession. Ours is truly a vocation. In its truest sense, it means a life to which we are called. Second, we're both concerned on promoting and restoring wholeness of life. The key words in our professions, health, healing, holy, and whole, share common roots in Old English. Third, and most fundamentally, we're both engaged in a moral enterprise. We both respond to those who are in need, those who ask us for help, those who expose us to their vulnerabilities, and who place their trust in us. So the three key points are that medicine is a vocation, a calling. At its core, it's directed towards restoring wholeness to the patient before us. And that as a moral enterprise, medicine is a covenant with patients and society grounded in moral obligations. If you combine the models, you'll see different points that come together, I think, nicely. There is the traditional expectation of expertise as well as a societal, social contract that allows the profession considerable autonomy. That this devotion to medical service requires a public commitment to values as essential to a society. And that at the heart is recognition of medicine's moral core, a covenantal relationship between doctors and patients. So to synthesize this, albeit in a tentative way, that professionalism is about acting for the good of the patient and finding the right healing action in line with the fourfold good. It includes personal responsibilities and behaviors related to the good of patient. It includes attention to social structures that harm the patient. I would argue that a robust, progressive professionalism must be aware of racism and injustice and the harm it does patients and society, while maintaining the vital call to act for the patient's good in a relationship that has deep moral grounding. And then finally, there is a need for negotiation with society and those who are at risk about the profession's responsibilities. Dr. Pellegrino took his approach to the profession of medicine by looking at the goal of the profession, that is the right healing action, and put this in the context of what's called virtue ethics. There are often three key questions. Who am I? What am I doing? Who am I becoming by my actions? And so a traditional way of looking at ethics is from the perspective of the meaning of individual actions and trying to figure out what is right or wrong or better and less bad. But we can also look at ethics from the perspective of the actor. What do our actions reveal about who we are and the type of person we're becoming? The virtues that Dr. Pellegrino talked about are used in an old sense derived from Aristotle and Aquinas, that these are character traits that are inherent, but they need to be exercised in order to develop into an excellent person. These traits, these virtues, are directed toward the goal of the right healing action. Traditionally, there are four virtues: fortitude, temperance, justice, and prudence. And again, you can think of these like muscles that need to be developed. So one lifts weights to develop, so you need to act with fortitude to be courageous. And the virtues are meant to act in concert to create a person who is living the best life, or who is performing the right healing action in the best possible way. The virtues in this way can be said to be of a mean. In other words, a person with courage is not a fanatic. One gets the sense of living the best life by observing role models in a community and by doing the practice of medicine, by exercising the habits of the virtue. Again, particularly important in a community that has values and excellence and encourages models of who we should become and how we should act. Again, virtues are habits that are exercised in the end of living the good life. And in medicine, the good is the healing action in the doctor-patient relationship. Dr. Pellegrino lists some special virtues, but he also notes that an enumeration of the virtues is, as he put it, notoriously difficult. Among those, he talks about a fidelity to trust, benevolence, intellectual honesty, courage, compassion, truthfulness, humility, and what he would call phronesis, which is, as you guessed, a Greek word. And it really is the habitual disposition to make right choices in complex clinical circumstances. Think of the doctor who you most admire in her or his ability to care for a complicated patient in a way that shows technical skill, compassion, gets to the heart of the matter of what's going on with that patient, and then is able to come to diagnostic maneuvering as well as therapeutics in a way that is both elegant, kind, and healing. Dr. Pellegrino would never see the patient as a customer, that he or she rather is a member, and that we are members of a moral community that are committed to the welfare of the sick. One needs a community of virtues to sustain and reinforce commitment to the virtues. And talking about medical education, he noted, medical students usually agree that they know which of their classmates they would not trust to treat members of their family. And they're aware that the faculty is often uninformed or indulgent about serious character flaws in some of their students. Students are also aware that faculty may treat problems in character lightly or shy away from dealing with issues for fear of lawsuits or unpleasant encounters with other students or faculty. If the profession is to be resuscitated as a moral enterprise and not simply a branch of high-tech industry, medical students will need to devote significant attention to evaluating students and faculty and their institutional behavior by these standards as well. So the question that Dr. Pellegrino would ask is, how are you going to develop as a person, as a physician during your career? How are you going to answer the questions, who am I, what am I doing, who am I becoming by my actions? Now, if we look at the current context as I come to the end of my talk, we've focused on the goal of the physician-patient relationship. This relationship takes place in the midst of social inequity and injustice. To attend to the right healing action means that we must pay attention to those barriers that can prevent the fulfillment of the goal of the relationship. And those things that demean human dignity, racism, injustice, inequities, need to be addressed to the fullest extent possible, and then corrected by those in the profession. Thank you very much.